Hello to everybody. It's a real pleasure to be here with you virtually in Antwerp. Welcome to System Saving Live session. I am Federico Semeraro. I'm a consultant in anesthesia and intensive care from Bologna, Italy. I'm a chair-elect of ERC and a SEC BLS co-chair. It is a real pleasure to share this session with my friends Tino and Sebastian. We have today excellent speakers, amazing researchers, and very passionate professionals. So may the force be with you in this very hard moment for Europe and all over the world. So Tino, Sebastian, please introduce yourself.
Hi, welcome. I'm Tino Greif. I'm the current Director of Training and Education, and it's a pleasure for me to chair this session together with Federico and Sebastian. I'm an anesthetist in Bern, Switzerland. And with this, I go to Sebastian.
Hello, welcome everyone. It's a pleasure for me to be here and to co-chair this session. I'm Sebastian Schnaubert. I'm from Austria, Vienna, working in emergency medicine there. I'm also affiliated with ERC and ILCOR. And I'd say let's get started with our first session, with our first presentation, which will be given by Teresa. She's a consultant at anesthesiology, intensive care medicine at the University of Oslo, and she'll tell us news about apps, dispatch, telephone CPR. So Teresa, the stage is yours.
Thank you, Sebastian. Okay, I will share my screen. So good afternoon, I guess I could say, 2 minutes past. As the title would indicate, this lecture or presentation is going to be on three things: apps, dispatch, and telephone-assisted CPR. These are my conflicts of interest. So many of us use apps and cognitive aids every day, both in our clinical work and when teaching CPR. And it seems logical that that these are useful aids, but how good are they really, and do they really work? I think, as with everything in life, there are pros and cons. So on the plus side, I think cognitive aids and apps cognitive load. They can reduce stress and distraction. They can standardize the way that we communicate, and they can help us create a common situational awareness. Now, on the minus side, they could also promote fixation errors and groupthink, so that we're all sort of thinking incorrectly about the same things. They could impair communication and actually be distracting if they're not well developed. There we go. So a recent systematic review performed by ILCOR found pretty limited evidence on the use of apps and cognitive aids, and the evidence they found was a bit inconsistent. So I think perhaps a bit worrying, looking at the evidence they identified with using apps and cognitive aids in lay rescuers, they actually saw that for some of these aids, it took 2 to 3 times longer to get started with CPR when they were used, and that results for compression depth, rate, and hands-off was inconsistent. Some of them people seem to do better, some of them not. And in healthcare training, there's really not a lot of evidence for cardiac arrest, but there is some evidence in particular in relation to trauma care, where you see that using these types of aids leads to fewer errors and quicker exam. And if it works for trauma, it's not that unnatural that it could be useful for cardiac arrest as well, so for professionals. And apps are, I think, increasingly being used in many systems to aid the communication between volunteer rescuers and the emergency medical dispatch. And I think now we have quite a lot of research evidence to show that these types of systems and apps are feasible. They work. They are common, or they are in common use. And actually, volunteers can get to the victim before ambulance personnel in a quite substantial proportion of cases. I think the latest paper that's reviewing this would actually suggest that outcomes seem to be better with these systems. So emergency medical dispatch, I think, is still increasing. We're still realizing its importance in both our guidelines and research, and I think it's getting an increasing role in our resuscitation work. And why is that? Why is dispatch important? Well, I think the simplest reason is just looking at outcomes in patients where cardiac arrest is recognized by the dispatcher. You can see that it really affects everything that comes after. So if the dispatcher is able to recognize that this call is about a cardiac arrest, you're already sort of ahead of the game. So I think we're doing an increasing amount of research and reviews on the role of dispatch. And one of the reviews that has been done by ILCOR is looking at how well do we recognize cardiac arrest in dispatch. And as you can see, there are quite a lot of studies that have evaluated this, especially how good are we in recognizing cardiac arrest. A bit harder to study, all the cases to look at specificity. But I think the striking point in this review is the range of our dispatch centers. So I think this really underlines the need to monitor, research, and improve our dispatch, because some centers are doing really well and some have some way to go. So another review looked at dispatch instructions. How important are they? And the first review was basically comparing systems that offer CPR assistance to systems that do not offer telephone CPR. And I think, not surprisingly, a good system is better than a bad system. So the other part of this review was comparing outcomes for patients on an individual level. So comparing outcomes for patients that received CPR to those that did not. I think, not surprisingly, patients or receiving telephone-assisted CPR was associated with a better outcome compared to patients that did not receive any CPR. But perhaps more surprisingly, it was comparing the telephone-assisted CPR to standard CPR. So comparing outcomes for patients that received telephone CPR to those that received CPR by someone that already knew how to do chest compressions. And I think the good news is that the outcomes were pretty comparable. So what kind of instructions should the dispatchers be given? Well, I think what we have now, we have 3 randomized controlled trials comparing instructions to standard CPR versus compression only. Now, these are for patients that don't really know how to do CPR when they call the emergency service. And as you can see, if we combine these 3 studies, it's really leaning towards better outcomes when we keep it simple. And it's not surprising, because CPR isn't that easy. Teaching people how to do mouth-to-mouth ventilation over the phone is no easy task. So there is a pretty clear recommendation to do compression-only instructions over the phone. So the most recent review from ILCOR looked at using video in dispatch, and there's not a lot of evidence out there. There's quite a fair amount of evidence just testing the concept in mannequin simulation studies, and I think it is a promising and interesting concept. I think a lot of things are hard to explain over the phone, and if you can have video, which I think more and more people are using for normal communication, then obviously that could reveal a lot of useful information. So the one observational study that was identified showed, just in sort of unadjusted analysis, that patients that were treated with telephone or video dispatch CPR did better than those that did not. But obviously they were not selected, they weren't comparable. So the different statistics that they did to try to even out those groups then failed to really show that video dispatch was superior. But I think this is an interesting area, moving forward, and I think we're going to see a lot more evidence on this moving ahead. So to sum it all up, I think apps and cognitive aids might be useful in some settings, but they are probably not useful in all settings, and every aid is not useful. And I think, again, cardiac arrest recognition and quality of CPR can be improved by improving your emergency medical dispatch. It's probably the most efficient way of improving outcomes for most of our systems. Thank you.
Thank you, Teresa, for this amazing presentation. A lot of technology, you know, I am a geek. I love the idea to use in the future the telephone mobile for everything, also included cardiac arrest. So I will introduce the next speaker, but before you can turn off your slide, please, Teresa. Oh. And please, to all attendees, I saw there is some question on Slido. Please send us your question, and we open the discussion at the end of all the lecture. And now for the next speaker, it is a real pleasure to introduce you, Joyce Young. Joyce is a consultant in anesthesia intensive care, a professor at University of Warwick in the UK. Joyce, it's a pleasure to be with you virtually here and not in UK at the moment, unfortunately, but please, Joyce, the stage is yours. Enjoy.
Thank you, Federico. It gives me great pleasure, and thank you for the opportunity for me to present to you today. My topics are rapid response systems and cardiac arrest centers. And what I would like to do is take you through our recommendations, ERC recommendations, and then hopefully give you some insights into why we decided to write these recommendations. So my conflict of interest, I don't have any commercial conflict of interest. I certainly work within Resuscitation Council UK, involved with the guidelines writing and also with ERC. And I suppose for this particular presentation, these two topics, I was involved with some of the evidence, look at the evidence and trying to come up with a recommendation. So I'm very happy to talk to you about this. The first recommendation is in relation to early warning scores, rapid response systems, and medical emergency teams. And our recommendation from ERC is that the introduction of rapid response system should be considered to reduce the incidence of in-hospital cardiac arrest and in-hospital mortality. So just a little bit of background, why we decided to include early warning scores, rapid response system, and medical emergency teams all together. It's because we know that patients who are unwell and coming to hospital is at risk of deteriorating. The research also shows that 80% of these patients will show signs and symptoms of deterioration in the days before they sustain a cardiac arrest. So there's a great opportunity for us as healthcare professionals to intervene and certainly improve the outcome. Now, rapid response system is designed to improve the safety of patients, of those who are admitted to hospital, but it is a hospital-wide system and it includes early detection through protocols. So it includes early warning system, and then also a tailored response where healthcare professionals can raise concern and call for help appropriately, which leads to the activation of medical emergency team. And very important to know that when you consider the evidence, it's very difficult to separate all these elements, and they should really be considered all together. So in deciding what we should recommend, there is a systematic review and we look at the evidence. And this was done way before, and it was updated in 2015. And then we looked at the evidence again in 2020. We managed to find 57 observational studies and 2 RCTs. One was done in Australia and one was conducted in UK. We found low certainty evidence to support the introduction of rapid response system. We found improved hospital survival and also a decreased incidence in the number of cardiac arrests after a rapid response system has been introduced. There also seemed to be a suggestion that there's a dose response effect. And what we mean by that is that there are better performance in high intensity systems. So those systems that are activated more regularly and has more senior medical staff on the medical emergency team seem to have better results. However, there are other benefits to having a rapid response system. I think the clinicians involved, the healthcare professionals involved, are used to dealing with a medical emergency. And they're also very useful, probably, to provide better end-of-life care. And because they are embedded within a system, we have better patient safety, and we're able to reduce medical errors altogether. So some things to consider when you look at rapid response system. I think in many healthcare systems now, a rapid response system or a version of it is almost compulsory and mandatory. But it should be considered as a whole system response, and it's actually quite a complex intervention. I will tell you at the end that there's a very nice review article that I'll recommend you, anyone that's interested, to look at this. And if you look at the whole system, there is a cycle, and there's an afferent limb and an efferent limb. First of all, you need to educate staff to be aware of the importance of looking after patient at risk of deteriorating. They need to know when to monitor for vital signs and how to monitor it, how regularly, and what to do when the vital signs are sending warning signals. There should be clear guidance to enable staff to raise awareness and also their concerns about patients. And there should be a clear system of response of who should be called at what time. And this whole system, wherever you are, should be reviewed regularly, because things could change. And sometimes critical incidents will bring in changes to the system that is needed. So in 2007, there was an outstanding reporting for system intervention and a recommendation of what data we should be collecting. And I think for people who want to do research and want to do quality improvement, this is a must-read article. Unfortunately, when we gather the evidence, it is very, very clear that the data that is reported is very different. There's a huge amount of heterogeneity, which meant that the evidence that we can collect is rated very low. And so going forward, I think for anyone that should want to look at research in this area, they should collect data that's recommended in this paper. The second topic is cardiac arrest centers. And our recommendation is that treatment in cardiac arrest centers provide the best outcome for patients. And where possible, adult patients with out-of-hospital cardiac arrest should be cared for in cardiac arrest centers. And just a little bit of background, cardiac arrest centers are hospitals that provide resuscitation treatment that include emergency intervention cardiology, such as PCI and angiography, and then also critical care treatment for post-resuscitation care. And that will include temperature management, cardiorespiratory support, and then also the use of neurology to improve prognostication. So looking into the reasons why we recommend that patients should be careful in cardiac arrest centers is that we did a systematic review, actually started in 2018, but that was published in 2019. Now, this seemed to be and would appear to be quite a straightforward process. We're comparing care at cardiac arrest centers versus non-cardiac arrest centers. But there was quite a lot of difficulty when we assessed the evidence, because the definition of cardiac arrest centers is not universally accepted. So although there were 17 studies from around the world, many of them registry-based, there is very low certainty of data because of differences in emergency systems and also hospitals. What we found is that there is improved survival with favorable neurological outcome at hospital discharge, and also improved survival to hospital discharge. However, this is based on adjusted data from observational studies. We're still waiting for the first randomized controlled trial. The evidence was limited, so we couldn't look at whether the patient should be primary transferred or secondary transferred to cardiac arrest centers, what protocol we should use or triage, how we should triage patients, whether the presentation of patients should lead to different transfer protocols, and whether there's any evidence in the pediatric population. I'm happy to report that there are more papers that's now been published since we done this systematic review. And what we're hoping to do is do evidence update in 2021 or 2022. This is a key publication by the Association for Acute Cardiovascular Care, and it's a collaboration of European Resuscitation Council, European Society of Cardiologists, and other organizations. They have looked at evidence and they have recommended that countries should look at, or healthcare system should look at adapting a out-of-hospital cardiac arrest center network. So for those hospitals that do not treat cardiac arrest, transport should bypass this hospital to go to a cardiac arrest center where treatment can be provided. And in rural areas where patients might have been admitted to an initial hospital, these patients should be considered to be transferred to cardiac arrest centers. And then there is a second tier of hospital called cardiac arrest hub hospital, which are bigger hospitals that can provide specialist treatments such as eCPR. And these should be used as secondary transfer or direct transfer for appropriate patients. So in summary, for in-hospital cardiac arrest, we recommend the introduction of rapid response system. And in out-of-hospital cardiac arrest, what we want is to care for adult patients in cardiac arrest centers. These are the key references that I think people should refer to if they're interested in looking further. And then I just want to acknowledge my colleagues who helped all of us produce these guidelines. Thank you very much.
Thanks, Joyce, for this excellent presentation. And I guess you answered some of the questions in Slido. Thanks to all of you for your question in Slido. We will answer and discuss the main questions after all the presentations. And with this, I would like to introduce our next speaker, which is Andrea Scapigliati from Roma, Italy, a consultant in cardiac anesthesia and postoperative intensive care medicine. And he also has quite a lot of function in the Italian resuscitation councils. Please, Andrea, the floor is yours.
Thank you so much for inviting me. I hope you can see my screen. My issue is a strange and new issues on these new guidelines, community awareness campaign. I would like to show you in the next few minutes how this powerful tool can help us in spreading the reason why we are here, that is improving survival and improving the survival of our patient, of our cardiac arrest victims. Those are my conflict of interest, intellectual one. And we know one of the key message of the new guidelines are again that the utmost importance of what Brady recently defined as the pre-arrival care. That is what the lay people can do before the intervention of a medical system on the field. Bystander CPR, we know, and the early use of defibrillation can improve survival of our patients. And we know that the core elements of this pre-arrival care are recognition, call for help, chest compression, and defibrillation, early defibrillation. That's why our efforts are in moving our bystander, our general population from a barrier situation with for fear or reluctance. They don't want to intervene, to a new situation, a change in their behavior in which they can be willing to react to a person that is unresponsive and not breathing. Of course, with the support of a system again, and that's why we are in the right session. The system that saves lives. That's why a lot of intervention have been implemented so far. I apologize if I wasn't able to mention all the worldwide initiative we had so far. And in a recent systematic review from you and these groups, we know we can find a very important message. Interventions addressing community or community plus health services are able to improve two main outcomes, survival and bystander CPR. Both alone as community intervention, intending intervention to address lay people mainly and not the healthcare system, and the combination of community plus health service intervention. But what we need to know better is if our intervention, what we implemented so far, is able to improve the lay people response. You and the authors tried to understand this aspect, removing from those studies involving, for example, the first responders with a duty to respond as firefighters or policemen, and they find again that those interventions are able to improve survival and bystander CPR. However, these studies included one intervention that can be confounded, that is emergency communication circuit dispatch and distractions. So we try to understand if there are interventions that are able to impact on the specific response, lay people rescuers for the community, for a general population. So we excluded studies that can be influenced or confounded by other interventions that were addressed in other reviews during the guidelines process, evidence process. For example, PAD program dispatch, as I told, and impact of social or economic factors of CPR protocols guidelines changed. On behalf of the Education, Implementation and Training Task Force of ILCOR and the ERC writing group, we performed a scoping review with a narrative review of the literatures addressing this specific aspect, and we tried to define better those interventions. Community for us was a general population of a studied area. Initiatives were those interventions aimed to increase the engagement of the community as defined in providing BLS, and bystander CPR was the response in terms of BLS of people who are not a part of an organized emergency medical system. We aimed with this definition to focus our attention of the response of a community of lay people again. We were able to include 19 studies in our scoping review, and those are the characteristics of the study. Many of them are from North America, few from only one country from Europe, Denmark, and other from Asian countries. The overall quality of the studies is not so good. Most of them are observational studies. And the most reported outcome was bystander CPR, while survival outcomes were less reported. To facilitate a narrative summary of our result, we try to group the intervention in three main categories: training, mass media, and bundle interventions. Bundle intervention were the intervention in which interventions included medical emergency system or hospitals, but in which the component consistent with lay people response was clearly isolated and measured. These are our main results. On this side, you can see the three categories: mass media, community training, and bundle intervention, and their impact on the outcome we considered. As you can, in the green box are the studies who supported a positive effect of initiative on the main outcomes, and in yellow the boxes are the studies that did not affect the considered outcomes. As you can see in a glance, most of the studies, most of the initiatives were able to improve bystander CPR, provided, and this is a main aspect I would like to highlight, provided that were initiatives that were prolonged in time, the initiative that wasn't a one-shot, one-day initiative, and initiatives that were well designed and targeted on specific groups or specific areas and on specific objectives. We know very little about mass media campaign. Only two studies were included in our review. So we know that probably bystander CPR is the best outcome that can measure lay people response compared to other survival outcomes, in which, of course, the influence of the healthcare system are more pronounced. Bundle interventions are probably the best to improve our outcomes, but it's very difficult to isolate in these studies the component related to lay people. Instructor-led training is still the most used intervention. And generally speaking, most of the included studies reported improving bystander CPR. That means that we have in our hands a powerful tool to improve bystander response. What we do not know still, we have poor quality study designs. We need a better definition of what we are looking for. And unfortunately, all of the studies are coming from high-income countries, and this limits generalizability to other parts and areas of the world. We need to know better what is happening in Europe. Only Denmark published results on their activity. We need more about other cardiac arrest, not in adult population. We need definitely more information about costs. Community initiatives are demanding in terms of financial and human resources. So we need to know how much they need. And we need, of course, to be more targeted. And we need to know if we have in our end other intervention other than training. To summarize, community awareness initiatives are probably powerful tools to improve bystander CPR and then in turn survival of our cardiac arrest victims, provided they are targeted. We have intervention that can address individual through education, training, and motivation. We need something that addresses the social environment in which we live, with media and all those interventions able to disrupt the barriers to perform bystander CPR. We need a better organization in terms of bundle, dispatch, and upside, as we heard a few minutes ago. Last but not least, we need a political intervention with laws and regulation can facilitate the intervention of bystanders and lay people in the response to cardiac arrest. Again, is a system response. That is the main message I would like to leave you. Again, we need a systematic response to cardiac arrest, in which a lot of intervention are needed. And with this in mind, I think we can approach better the worldwide awareness campaign. I'm sure all of us are involved in or will be involved in from now on. Thank you very much for your attention.
Thanks, Andrea, for this presentation. And of course, talking about community campaigns, this directly leads to our next speaker, who is Daniel Schröder from Germany. He's affiliated, he's an anesthesiologist, and he's working for the German military service and the University of Cologne. And most importantly, he's affiliated with the Kids Save Lives program that is spreading across the world right now, and he will give us some insights into that. Please, Daniel. Thank you.
Hey, hello. My name is Daniel Schröder from Germany. Nice to meet you. I will introduce you to the new guideline recommendations about Kids Save Lives. I have no conflicts of interest. The first that we know is that the willingness to perform CPR in school children is really high, it's above 80% in most of the studies. But we have another large problem. This is the problem of self-confidence in most of the pupils from the studies we know. These lack of self-confidence results from fear of legal liabilities, for example, from the fear of harming a person, and a huge point is anxieties about infections or diseases transmitted by CPR, by doing CPR. So on the one hand, we have a large willingness in the population of school children to learn and to perform CPR, but on the other hand, we have a lack of self-confidence. And this gap is to be closed, because we have this high willingness is, in my opinion, is the key to success for everything. And this gap between willingness and lack of self-confidence is to be closed by the new guidelines, or by guidelines recommending clearly statements related to Kids Save Lives. So we published a statement, the ERC position statement on CPR and school children resuscitation, and I would just introduce you a few points. And the first, and in my opinion, the most important recommendation is that we recommend as 2 hours training per year, every year, from the age of 12 years or earlier. So there is a little evidence for that, just a little. The reason for these the cutoff at 12 years is that we know from a couple of studies. This is a study of Christian Abelarras Gomez. It's a very, very nice study that we know that the chest compression death is increasing from the age of 12 to efficient chest compressions, not only in boys but in girls as well. So this is the reason why we recommend resuscitation maneuvers from the age of 12 years. And why do we recommend 2 hours per year? I think it's really important that we underline per year. This is an annual training recommendation, because we know that on the one hand, age is a predictor for long-term self-confidence. The older the children, the better is their performance. And a training, as many trainings are conducted, the better the pupils. This is not only in practical performance, but also in detection of cardiac arrest and theoretical knowledge in general. So the second recommendation is that we recommend training in a two-step approach. The first step is to just teach the check, call, and compress approach. It's easy, and everybody all around the world should know that and should be familiar with the check, call, compress approach. And then a second stage, we recommend teaching ventilation maneuvers and automated external defibrillators. This is, to be honest, there is not that much scientific evidence for that. So we just focus mainly on this check, call, compress approach for the first time. So who should teach? There's a lot of studies who is the best teacher. For example, physicians, pupils by themselves, older pupils, EMTs, paramedics, medical students. And the evidence is that everybody is able to teach, and the outcome is almost the same. But we recommend teachers as teacher, because this is the most practical and practicable approach. Because teachers, on the one hand, are familiar with their own pupils, and they have a pedagogical education as well. But we know also from other studies that the teacher by themselves are not really familiar with the topic, with the issue CPR or cardiac arrest. So we recommend a minimum of 4 hours CPR for every teacher who is teaching CPR. So we in Germany, with the German Resuscitation Council as well as others, recommended or loaded up some curricula for teacher training, and we're still working on that to distribute this knowledge to as many teachers in Germany as well as possible. So what do we recommend how this system is working between school teachers, the German or the ERC, and the pupils? So we calculated a number of 1 teacher per 100 school children, or at least 10 teachers for 1,000 school children. And we recommend that each school should have at least 1 teacher to be responsible for the education of this school. This is really important to manage, to stay in contact with the teacher, and to, for example, adapt the guidelines, adapt recommendations, and keep this system running, keep the education running, at least or mostly in Corona times. The 7th and 8th point is how do we teach? How should we teach? So we have in Cologne, we have good experiences with low-cost mannequins for many reasons, because most of these low-cost mannequins is about 20 to 30 euro, and there are mostly donations. so we can buy for each class maybe about 20 low-cost mannequins, and each pupil is can take them at home. So, and there is a really important side effect with that, because we saw, there is a nice publication, we saw that these multiplier effects is important to train another maybe 4 of at least 3 other persons by these pupils, so they know, they get their knowledge, bring their mannequin at home and show it to their siblings, to their sisters and brothers, and this is a large side effect and really good to have. The last point is saving life is a child's play. We saw that, or we realized this, that these school children, or at least the youngest school children, they really like to be educated in CPR, which is on the one hand good for this multiplier effect, but on the other hand, it allows us to start CPR training earlier than 12 years, than the age of 12 years, because maybe the CPR is not that effective before 12 years, but they become familiar, they reduce their anxieties, they having fun with it, and probably give their knowledge to as many people as possible, maybe the older. So this is a large approach for sustainable education. There is one problem that we have. We recommended this maybe for 6 or 7 years ago, I guess, but only a few countries in Europe made it as a legislation. It's just 6, and we hope to include this recommendation by the WHO, or this recommendation by the ERC, to include this in the curricula, so that we made as a legislation that school children are trained 2 hours per year as a legislation. Yeah, that's it. Thank you very much.
Thank you, Daniel, for this nice presentation. Amazing. You know, I am a fan of Kids of Life. This is my major conflict of interest. So guys, we have a lot of time for questions. So I asked the speaker to turn on the video, and please, Daniel, can you turn off the slides, please?
Sorry.
Okay,
sorry,
excellent.
sorry.
Back on virtual Antwerp. Welcome again. So Teresa, you want to respond to some of the question you replied to the attendees on the chat? You want to underline some of the question? You want to reply to some of them?
Yeah, so there were different kinds of questions. I think some questions on compression only in the setting of dispatch. I think the question of compression only versus standard CPR is always controversial, and I think there are strong opinions going both ways. And I think, you know, the evidence that we do have is presumed cardiac for presumed cardiac cause arrests, then trying to teach someone to do mouth-to-mouth ventilation is not a good idea. I think I think my response is, you know, it doesn't become easier to learn how to do mouth-to-mouth ventilation for the first time over the phone if it's a child, or if it's some non-cardiac cause, or if it's drowning. But, you know, it starts to get complicated to make good recommendations, because we certainly don't have high quality evidence to guide that. But I think that's how we need to weigh it. I think the issue is it's a hard skill to do. I think, yeah. So I think I don't know if I can answer that any better than that, or if anyone else on the panel has anything to add to those questions on compression only.
Okay, thank you, Teresa. A very quick round around. Joyce, you want to reply to some of the questions? You are very active on the chat. You response to some of the questions. You have to add something extra information to the attendees.
One of the questions that I was asked was, it's all very well and good that evidence shows us that we should care for patients in cardiac arrest centers, but do we need new hospitals or new network set up? And I think from evidence point of view, it shows that care at cardiac arrest centers, those centers that are designated care centers with the appropriate available treatment, does improve outcomes, but it doesn't tell you how you should apply the finding into your existing health system. So it is a difficult question, and we did think about that. One of the suggestions from the European consensus paper, which I think make a lot of sense, is to make use of the existing STEMI network for ST elevation MI network to provide cardiac arrest centers. And then when you go to the cardiac arrest hub, which are the bigger centers, those will be the specialized, what we would call a tertiary referral center. And I think the hope is that it should mirror the trauma network or the successes of the STEMI network. So I thought it was a really good question, but it's difficult to answer because it will depend on your healthcare system and whether you have the resources to support it.
Okay, thank you, Joyce. Tino, I'm muted.
May I ask, Daniel, because there are quite a lot of questions, could you again stress out this question about age, when kids could be taught of CPR? Because once you mentioned a certain age, but the guidelines now are talking about kindergarten. And there's also a question about activities on the legal or official level, European community questions to bring in CPR training into schools.
Yeah, sure. This is a discussion for since ever, for a long time, because we know that the effective chest compressions, effective practical CPR is about 12 years. The age need to be 12 years, but the discussion, or 50 kilograms. So you need to do good chest compressions. You need about 50 kilograms. But children are playing and to get and becoming more familiar when they start earlier. The learning process is just the learning process is started earlier, so they become better in the end. If there are 12 years and they just had some training before, they are performing way better. This is what we know from the studies. And on the other hand, is the discussion is there anything bad if a younger child starts CPR? We don't know. Maybe it's an ethical question. Maybe it's a practical question. What we know is that there is the theoretical knowledge can be activated or reactivated really before 12 years. So if there are younger children performing in the theoretical tests as good as other children as well. So when do we start? I don't know. There is a lack of scientific evidence because it's really difficult to perform studies earlier than 2 years. The most 12 years. Most studies were conducted between 12 and 16 or 18 years. So this is not very new, and so we urgently need studies with school children under the age of 12 years. This is all I can say.
Thanks.
Thank you, Daniel. Andrea, there is a very nice question for you, very off topic, I can say, from Carlo. How we can react to COVID-19 pandemic, how we can restart in the community, how we can restart awareness in the community, and try to find a balance between increased awareness and protected community. Very hot topic for you.
For all of us, I think, not only for me, I think COVID pandemic is one, is a one more fear to address when we have to convince our communities to react properly to cardiac arrest. I think we have to be honest and to say exactly what science says to us. I mean, the risk to be infected during resuscitation attempt. I hadn't the time to say that most of our intervention proposed chest compression only CPR, and that means that chest compression only CPR could be what we have to teach to our communities. It means that the harm to be infected during chest compression only CPR is very low, and so we have to be honest and to say what science is telling to us so far.
Thank you, Andrea, for your nice response. There is a question for Teresa about apps, and I support your response to that after as education part of BLS. What do you think about the risk of apps to reduce attention on courses?
Well, I certainly hope that it wouldn't reduce courses, and I don't think we could we couldn't substitute a good CPR course with trying to learn on the fly over the phone. So it's certainly not meant to replace. I think it needs to come in addition. And hopefully it's additive effect where, you know, the more apps you have, the more social media, the more people hear about it and know about it, the more people would actually want to go and do a proper course and learn how to do it properly.
Thank you, Teresa. I'll try to launch a teaser for Restart courses. There is a session dedicated to Restart courses. I totally agree with you. We need to some experimental. We are in experimental phases during COVID-19. We have to restart the courses in a blended way with the technology on site as we can. So I will invite you to Restart courses session led by Tino. Tino, you want to add something from educational side on that?
I invite you to the session tomorrow. In short words, you have to provide education. If you don't do it, people lose their competence. We know that this resuscitation is a practical hands-on competence. And if people are not trained after 3 to 6 months or latest after a year, they are at the level before attending whatever course. So having brush-ups, refreshers, at least once a year or even more often, very short interventions, half an hour, 35 minutes, over time is far better than the big bang of one course every couple of years. And we have to do this. This is our job. And people in clinics, healthcare professionals, they are working now in this COVID environment and they have to provide CPR anyway. So train them as they are acting afterwards.
Thank you, Tino. And there is maybe a question for Joyce and Sebastian about how we can implement, how we can manage the rapid response system in low resource setting. Sebastian lead in the working group this, maybe after Sebastian want to comment. Joyce, how we can implement the rapid response system in low resource setting? Before Joyce and after Sebastian, thank you.
I think is a very good question and interesting to think about. Obviously, a lot of the evidence come from health system where there's no, not necessarily any resource issue, and to implement a good rapid response system, I think you need a system thinking and resource to invest into implement such a system. So this may be an issue in low-income countries. However, I think there are certain things that perhaps could be provided, and to start off with, that it doesn't need to be a full working electronic system. Early warning score started off with paper format, with basic vital signs monitoring that doesn't necessarily need a huge amount of investment in new machines. However, I think the main resource intensive part of rapid response system is people and training of people. So I think if I only had a very limited budget and I want to introduce rapid response systems in low middle income country, I would invest in people and train them to respond to abnormal vital signs and start a treatment. And then hopefully the rest, when there's resource, that could be instituted. So that would be my thoughts.
Thank you, Joyce. Sebastian?
Yeah, the whole question of low resources and resuscitation is, of course, very interesting. And ILCOR and also the ERC are trying to address these questions over the next course of month, years. Let's see how this works out. But we have to, of course, before we make suggestions, we have to gather data, and we saw in scoping we 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 gather data, and
yeah, maybe. Yeah, there is some force inside you. Maybe there is some force.
Yeah. So what I wanted to say is, in the scoping review, we saw that there's really very variable data on outcomes, on resuscitation itself from low resource settings. That's the big question of how to define low resource settings. So this is a topic that needs more working on, and we hope to provide some preliminary answers to that in the near future, I'd say.
Thank you, Sebastian. Any other question, Tino? Yep.
Maybe a last question which also came in the chat to Teresa. There's some person mentioned there might be a delay in dispatcher assisted resuscitation, that people wait before they start. Do you have any idea how we can close this gap?
Well, I think working with quality indicators. Working with various quality indicators within dispatch to shorten that time, I think is an important way of improving the dispatch role. And I don't think it needs to be 3 or 4 minutes in general. But again, I think it's also speaks to the point where we can't replace CPR training with learning, learning on the job. We need people to take courses, and we need a lot of people to know how to start CPR. And hopefully dispatch would be, it could help give you feedback and cheer you on and remind you and kind of help you with the confidence you need to keep going, more than explaining it to you for the first time.
Thank you, Teresa. So we have only 2 minutes. I will ask you, from you, Teresa, hashtag very fast sentence about your content and your presentation in 2 seconds from now.
I think apps are here to stay, and dispatch continues to be important.
Thank you, Teresa. Joyce?
In hospital, rapid response systems save lives, and out of hospital cardiac arrest setting, we need to look at cardiac arrest centers.
Thank you, Joyce. Andrea?
Well, community initiatives can improve bystander CPR, provided that they are well targeted, well designed, and probably we need help from professionals who usually sell some drink or whatever to learn how to be more effective in impacting communities. Thank you.
Okay, this is a tweet, not a hashtag. Thank you, Andrea. Daniel?
Willingness is the key to success, and check call compress.
Thank you, Daniel. And from the other, my friends, Tino, your final hashtag?
To teach CPR and apply CPR.
Sebastian?
Remember the bigger picture, and remember it takes a system to save lives.
Okay, my final hashtag for all of you, obviously, live long and prosper, and spread the word about system saving life. Thank you very much indeed, and enjoy the rest of the Congress. May the force be with you always.